No.
My name is Shiela Appavoo. I'm a general radiologist with an interest in breast imaging, and I've been in practice since 1994. We're seeing younger and younger women getting breast cancer, and so the evidence is fairly clear that there's a benefit starting around age 40. The guidelines start at age 45, and so we just recommend that women have that conversation starting at age 40. For most women in Alberta, starting at age 45 is by invitation to get a mammogram, and you don't need to get a doctor's request or requisition once you reach age 45. A lot of people who are breast experts, so breast radiologists, breast surgeons, oncologists, will recommend actually starting at age 40, but for that in Alberta you need to get your doctor's requisition for the first time so that they can have a discussion with you about risks and benefits of screening. It's really important to talk to your doctor starting around age 25 about your family history. We don't want to miss our chance to catch things early if you do happen to be in one of those families with a really strong risk of breast cancer. And it's often linked to ovarian cancer as well. So if you have a family history of breast or ovarian cancer, talk to your doctor starting around age 25 to see if you are one of those uncommon women who needs to start before age 40. You have a much better chance of surviving breast cancer if you can catch it early. And what most studies show now is that if you have breast cancer, if it was found with screening, your chance of surviving is about 50% better than if it was not found by screening. So if you found it by finding a lump or some other breast change, you don't have as good a chance of surviving the breast cancer as you do if you had found it by screening before you could find it, because it's smaller. If you can't feel it, we can find it on a mammogram or a breast ultrasound when it's much smaller than if you wait until you can feel it, and smaller is better. Treatment is not always, but frequently less severe if you catch a cancer early. And it does partly depend on the age of the patient, what type of cancer you have, what cell type, how aggressive it is. All of those things play a factor in what kind of treatment that you're going to get. But in general, smaller tumors result in smaller surgeries, and the patient may not even require chemotherapy. It's not a one-to-one correlation of size alone, but all of those things are better if you can catch it smaller. Any potential harm caused by the radiation is so small that we can't even measure it. The benefit is you have about a 40 to 50% higher chance of surviving a breast cancer if you find it with screening. So, over the course of a population, we can't know any individual person's risk of getting a breast cancer caused by a mammogram. All we can do is look at entire populations of millions of women who've been screened, and we've never actually been able to identify cancers that have been caused by radiation. In fact, in screened populations, what we are finding is that there are lower levels or lower rates of invasive breast cancers, because when we screen, we actually find some of the precancerous lesions and take them out. So if anything, it decreases your chance of having an invasive breast cancer if you're in that population that screens. Screening is something that we do on patients who have no symptoms of the disease. Diagnostic is when somebody has a symptoms. Those kinds of symptoms are things that we would then investigate using imaging, and that would be considered a diagnostic use of the tool. the mammogram is still the first test because it finds those early precancerous changes that can help avert an invasive breast cancer. So invasive meaning it's gone into the tissues around the lump and can then have the potential to spread elsewhere in the body, like the lymph nodes and the bones and the liver and so on. So finding it, nipping it in the bud before it gets to that stage is really helpful in preventing metastatic disease, metastatic disease is really what causes death from breast cancer or from any kind of cancer. One of the recognized harms of breast cancer screening is that you may get called back, and it's unpleasant, very unpleasant. You might get a biopsy. About 1.4% of women who have screening mammograms end up getting a biopsy. And of those, about 30 to 40% are cancer. And they are a very necessary part of the process of screening that helps save half of women. The biopsy needle running through it that was performed during a biopsy, and as you can see, it's the left breast. This is the 3 o'clock position of the breast. If you think of the breast as a clock face, that's to the 3 o'clock radian, and that's 3 centimeters from the... Overall, the risks of screening should be weighed against the risks of not screening. You're taking a risk when you don't screen, just as you are taking risks when you do screen.